This is Dr. Jason Lee, clinical immunologist and allergist. Welcome to Lecture 3. We're going to be talking about the epidemiology of asthma, and in particular, we'll talk about severe asthma. Approximately 8% of Canadians aged 12 and older are diagnosed with asthma. This number is similar amongst other developed countries, with some aberrations in places like Australia where they seem to have a little bit more asthma than Canadians. Asthma kills approximately 500 Canadians a year and sends about 150,000 for hospital for treatment. In the United States, approximately 5,500 deaths are reported as a cause or effect of asthma. Now, we look at different concepts and facts that we need to understand with respect to asthma immunology. As I mentioned, our body has evolved various mechanisms to deal with different infections. When it deals something as big as a parasite, which is much larger in size to cells, the immune system really requires a coordinated effort to surround the parasite and mount a vigorous inflammatory response. This will involve neutrophils, eosinophils, macrophages, and T effector cells that have to get to the sites of inflammation and help out their brethren in combat. Many of these cells will also have the help of antibodies, both IgE and other antibodies that are floating around. In addition to this, complement proteins will form complement activated membrane attack complexes. This will further activate and increase the propensity of cells like eosinophils and mast cells to degranulate, releasing more toxic mediators such as major basic protein. Eotaxin, which is the thing that recruits eosinophils, technically a chemokine, will also be released every time an eosinophil is degranulated. Again, this will cause eosinophils from your bone marrow to go to the blood and get to the site of infection, or what it thinks is an infection. Over time, if this process continues long term, it results in some airway changes that are noticed. This includes smooth muscle hypertrophy, the muscle that surrounds the cells of the airways, leading to more and more bronchoconstriction. Interestingly, bronchial mucosa and nasal mucosa are layered extremely similarly. And when these are biopsied in asthmatics who have allergy-driven asthma, the changes are nearly identical, the cells that they recruit, and the density of inflammation that occurs. So what happens with inflammation? Well, the main inflammatory cells are eosinophils, mast cells, T lymphocytes. Their inflammatory mediators include cytokines, chemokines, histamine, major basic protein, and other pro-inflammatory markers. Again, when the innate immune system gets activated, this also releases things like nitric oxide from inducible nitric oxide synthase. This is something we can now measure with something called the exhaled nitric oxide test. In most cases, this will correspond to asthma activity and activation of the innate arm of the immune system in response to inflammation. Over time, airway remodeling occurs. This leads to functional and structural changes in the lung. There is denuded epithelium, goblet cell hyperplasia, increased collagen deposition, excessive mucus, mucus gland hypertrophy, thickened smooth muscle, edema, and vasodilation. Now, I'm going to take you through the immunology behind asthma yet again. Antigens get through the respiratory epithelium. It is presented and taken up by a dendritic cell. This dendritic cell then processes the antigen, and under cytokines such as IL-4, 5, and 10 will present this antigen to a CD4 naive cell. That CD4, aka the helper cell, will further differentiate into one of many subtypes. If it differentiates into a Th2 subtype, it will secrete IL-5, which again activates and recruits eosinophils. It will also release IL-4, 5, and 13, as well as IL-9. This will largely activate the B cells, causing them to turn into plasmocytes, producing IgE. Now, when tissue damage occurs, a similar process can occur. The tissue damage itself, such as from an infection that burrows through the epithelial cells or activates innate immune systems on the way down, will cause a Th1 predominant inflammation that can also contribute to asthma. That is all for this lecture.